Good morning, everyone. Thank you so much for inviting me to your research conference. Many of you know I've only been at Methodist a short time, so I started last June 1st of 23. So it's very exciting to be able to come out in person and meet everyone. So today, I'm actually presenting kind of on behalf of Ed Jones as well. He unfortunately was out of town, but he did ask me to come. Very important to him and provide an update for you. So with that, and before I start as well, so I'm here today, and then my newest member of our team, our IRB manager, Marion Olson, who started on March 25th, and I'll have her stand up. Marion is also here with us, and again, she wanted to come out and meet everyone and make sure that you knew who she was, so if you have specific research questions. So with that, I'll get started. So the Office of Research Protections, and my group is called Regulatory Oversight. So I don't know if you realize, but back in last January of 23, ORP as it's called, it was kind of split into two. Prior to the split or the changes, ORP included conflict of interest, responsible conduct of research, all of the regulatory committees, data governance, and lots of other initiatives. Ed Jones, he had a great vision, and he said, maybe that's a little bit too much for one director. And so when one of the directors, Mary Clancy, who most of you know, retired, he decided, let me just split that into two. So when he split it, my area became known as regulatory oversight, and then we have another area called the responsible conduct, research compliance and integrity, and Kirsten Madigan is the director of that area. So today I'm going to focus on my area because those are all of our regulatory committees. So ORP includes the IRB, the IACUC, and our animal committees, and all of our safety committees, so the biosafety, radiation safety, hazardous substances. We also have education and quality improvement, and then we also have research data governance. This is a really great slide because a lot of people don't realize that our office really does interact and engage and partner, if you will, with with departments, I should say, central offices, academic, clinical departments across the institution. So obviously, you guys, the department leadership and our PIs, our research teams, our basic researchers, critical to us. But we also work heavily with Rattel Bunge's group, who's Academic Office of Clinical Trials, who does the FDA type trials, the Office of Technology Transfer. So if you think about all of those new technologies and you want to do external collaborations, you're sending samples out or sending data out, our office is reviewing all of those MTAs and DUAs. Sometimes we get involved in review of contracts as well. And then grants and contracts. So we're also doing congruency reviews. So if you have federal funding, Israel is sending all of those to our office as well, and we're reviewing those against any protocol that you have. Our mission in ORP is collaboration and regulatory compliance. Collaboration, I prefer to use the word partnership. When I came here, I said it from the beginning, my style has always been transparency and partnering with you. Our office can only be as good as we are or not are is if we're partnering with you. So I can stand here and I can pass all the policies and procedures, but if no one follows them or if no one understands them, then that does not our patients any good or our researchers any good. And so we always want to make sure that whatever we're implementing, any new initiatives, we're working with you guys and we're partnering to make sure that we're meeting your needs. So I'm the director, have over 25 years of human subject protection experience. So, and in all honesty, coming here in the animal research was kind of new to me. I worked on the animal research side peripherally, if you will, just from working with the IRB. But coming here, now I have direct oversight of the IACUC. So that's really been a work in progress for me and a lot of exciting learning. My primary human subjects career was at MD Anderson, and so I came from across the street. I was there for 23 years. And then I went to UT Health San Antonio, which really kind of broadened my my research portfolio, if you will. If you could imagine, MD Anderson was mostly, if not all, oncology research. And then at UT Health San Antonio, which really prepared me for Methodist, I got to see a lot of other types of research, which was really exciting, and which is why I wanted to join Methodist. My leadership team, Marion Olson, who you met, who's our IRB manager, our newest member. We have Leola Griffin, who's joined us as our QI and education manager. She also has over 20 years of experience. And then another newest member is Melissa Mayer-Diaz. And Melissa has over 18 years of experience just in the safety. So she was the biosafety officer at UTMB. She also worked for industry as the biosafety officer, so lots of experience. The only thing I'll point out about this slide is, if you can see, just based on the experience here, just the combined and individual experience, it's a lot. And so they do bring a lot to Methodist, and they are here to help you with your research with all that knowledge and expertise. So our safety committees, and I won't go through this slide, but this is basically what our safety committees are over, what they provide oversight for. So our HSC, our IBC, and then our radiation safety committee as well. So the IRB. So the IRB does have driving principles. We go under the Belmont Report. An interesting fact about the Belmont Report, it was actually implemented on April 18th, 1978, which is my birthday. And so I always felt like, well, maybe I was meant to do this. So I thought that's always an exciting little fact there. But the Belmont Report has respect for persons, beneficence, justice. So whenever the IRB is reviewing anything, these are always the principles that we have to keep in the forefront. And then, of course, the Declaration of Helsinki, which many of you are used to, especially if you're conducting collaborative type research. IRB is complex. We have many regulatory requirements that we have to follow, from the Health and Human Services regulations to NIH to NCI, if it's an oncology trial, the Food and Drug Administration, the veterans, if we're doing research in the veterans population, and then DOD. So if we have DOD type funding. A lot of how we review protocols is driven by not just the type of research, so if it's clinic, drug, basic science, but also it's driven by the funding source. We have 3 IRBs. Our IRBs are composed of 3 chairs, and I'll show you their pictures. I think many of you, I'm sure, know them, but they do serve our community. Each chair also has a vice chair that's appointed to it, and we probably have about 15 to 20 members that serve on the IRBs. Those members are your colleagues, and so they include physicians and nurses, and some of our chaplains as well. We also have community members that serve as part of the IRB, and that is a requirement. So the IRB has the authority to approve research, and I'm sure many of you have seen your studies reviewed. So we approve, we require modifications, and occasionally we disapprove or defer as well. I think one thing that's important here to note is just that if the IRB does disapprove the study, the institution can't go back and say, well, we'll approve the study and you can do it. And so that's really clear in the regulations. The institution can say, so if we do approve a study and the institution doesn't think it's research that we want to conduct here, so it doesn't fit within our mission, they can say, we don't want to do that study here. And that has happened a couple of times. So our IRB chair. So Dr. Miller, who we call her our senior IRB chair. I think many of you know Dr. Miller. Lots of experience, lots of expertise. And she really heads our IRB operations. So she's been wonderful. We also have Dr. Petkova, who's a hematologist, and she's our IRB 2 chair. And then our newest IRB chair that started in January is Dr. Olga Walln, and Dr. Walln is our IRB 3 chair. So the IRB does review new protocols. We review continuing review of new protocols, reportable new information. And to that end, a new service that we started here, When I first came, we had lots of reportable new information. That could be anything small, like a deviation violation to your study. It could be something major, like there was a major patient safety issue, new adverse events. We had a backlog of those. And so what we decided to do to help get things through, help communicate with your sponsors and get you the information that you needed, we decided to form 2 committees. And we call these subcommittees of the IRB. And one of the subcommittees is what we call the R&I subcommittee. So anything that's reviewed by our local IRB under the local IRB oversight, it goes to this subcommittee first. They review it, they hash it out. They may reach out to you if they have more questions, and then they send it to the IRB. We find that the reviews are just much more streamlined. And Dr. Miller is the chair of that subcommittee. We also have an external IRB oversight committee. So these are those protocols that are not under the oversight of our local Houston Methodist IRB. And again, you have R&Is, reportable new information on those committees as well. Lots of R&Is that are being submitted. They're primarily reviewed by the outside IRB. However, there are issues that could be like systemic issues to Methodists. There could need to be a change in operations in the OR, I say, or the way we do things in the laboratory. So this external IRB oversight committee basically compiles all of those R&Is, they review it, and then they make a determination whether or not we need to make changes to our local processes and practices. Important to remember, they don't take the place of your IRB, they enhance that review. And Pauline Todd is actually the chair of that committee. So a few key updates that we've done in the IRB since I've been there last June. We've hired our expert managers. We've restructured operations to gain efficiency. We integrated what we call consent editors and expert reviewers, and I'll talk about those briefly. We added external reliance analysts. We found that most of our studies that we're doing right now are going to an external IRB, so we wanted to make sure that we streamlined that process for you. So we added coordinators that had experience with the external reliance process. We have FDA inspections. We have a reaccreditation process for our human subjects program, upgrading our toolkit to make sure that you guys can submit things and ask questions to our office, added new letters. We're trying to get communication out to you, so through an ORP Insights newsletter, and then lots of other things that we're doing here. So the consent editors, I don't know how many of you have actually had the pleasure of working with our consent editors. I would probably say this is one of the greatest services that we've added since last June. And these are individuals, they're senior writers, senior medical writers. And so if you do have clinical type protocols and you have no clue how to write an informed consent document, or you get an informed consent document from a sponsor and you don't know how to put it in the Methodist format and get it through our IRB, these individuals have expertise not just in writing and health literacy, but they also take your consent and make sure it has all of the regulatory requirements on it. You just send them the document and then they do the rest. We found that the number of changes that the IRB is requesting during the consent process has dramatically decreased just because these 2 individuals have been involved in that process. We have what we call expert reviewers. So we have 2 of them. Some of you may have worked with them already. Again, so if you're a new investigator to the institution and you have no clue what the IRB requirements are, how to submit a protocol, you can pick up the phone or schedule an appointment with one of these 2 individuals, and they can actually help you with your protocol and help you with those regulatory requirements. They can say, you need to put this in your protocol to make sure it gets through the IRB. So these are services that we will be expanding probably within the next 2 to 3 months, and I'll talk a little bit about that as well. But again, 2 critical pieces that we've added. We do go through, so the IRB, just like you guys as well, and you're subject to auditing by your sponsors. We're also subject to auditing. We actually report directly to the FDA and OHRP. And so the FDA comes through routinely and they audit the IRB. So we did have an FDA audit just this year. It was a routine remote audit, and we did pass with no issues. And this is really kudos to you guys and everything that you do. I've only been here since June, and as you know, an audit is looking back. They're not really looking forward. So this is all of the work that you've been doing here at Methodist since I've been here. So this is wonderful. AHART reaccreditation. We are going through a reaccreditation process for our Human Subjects Protection Program. Our application is due August 24. We will be reaching out to the departments. Reaccreditation not just includes our office, it includes your office. Site visitors will come on site next spring, and they will interview you guys. They interview us as well. So more to come on that. This is just a picture of our ORP Insights newsletter. IRB performance metrics. So we also, one thing I wanted to make sure, I can stand here and I can say, oh, we're doing a great job, everything has changed, but I need to prove it, right? I mean, you guys are all about data. And so with that, I wanted to make sure that we came up with key performance indicators, so KPIs for all of our safety committees and especially for the IRB. So we do have KPIs that we follow and adhere to. We're looking at volumes. We're looking at turnaround times. We will be sharing our KPIs on our websites in the very near future. And so we're working with IT right now to come up just with some dashboards for you. We hear you. We hear your concerns about turnaround times and how long things have been sitting in our office. And so we want to make sure that we're transparent. This will also help us to improve where we need to improve as well. And so just regulatory considerations. These are those things that go bump in the night, those things that just keep us up at night from an IRB perspective. Some of these are from Dr. Miller. Some of these are from staff in the office. Some of these are from committee members. I think, the only thing I'm going to point out on this slide is AI. A lot of you are dealing with AI right now. It's all over the news and social media. How do we deal with AI just in research? It's a big hot topic right now for the IRB. How do we review protocols? How do we make sure that we're following the regulatory requirements? Data governance and structure. So a lot of you want to share data, research data outside with your external collaborators. It's required for some of our granting projects as well. So we want to make sure that we have policies and procedures in place to do that. And then again, we want to make sure that we're fostering that collaborative research because that's what academic research is all about. And I won't go through these slides, but again, this is the AI, and these are the things, again, that keep us up at night from an IRB perspective. And then, the sharing of research data, sharing of research images is another big hot topic for us right now. So our strategic plan moving forward, first and foremost, we are a customer service department. At the end of the day, we are customer service. You guys are our customers. We want to make sure that we're meeting your needs. So to that end, there are some services that we will be implementing in the near future, a concierge service where you guys can schedule appointments with us based on your time, whether that's 7 o'clock in the morning, 6:30 in the morning. We want to make sure, again, that we're meeting your needs. To talk about your specific research project, to talk about an IRB determination. Collaboration, so we want more collaboration with your departments. This is a great venue to do that. So please continue to invite us to your sessions. And then Dr. Miller, as the senior IRB chair, she has been working again with Raquel Bunge's group to make sure that we're reviewing protocols even prior to submission to FDA. Roundtable discussions, our consent editors, more newsletters and newsletter articles. We're also developing a SharePoint site. So you can see when you log into the SharePoint site, again, if you're a new investigator, a new researcher, and you don't know where to start, it will say, this is how you develop your protocol, and this is all the way through study closeout. And so we're working with Ed Jones and his office right now on developing that. Community engagement. If you do have something in the community where you're going out to your patient population and you want us to tag along, reach out. We're there. We're happy to do it. Again, research data governance. We're working with Dr. Jones on this as well. And then just increasing our footprint in the animal and human world. And so this is attending national conferences and presenting at national conferences and partnering with more institutions and TMC to make sure that we're benchmarking against best practice. this is how to reach us. And so all of our email addresses are here. And thank you so much.
That's like, well, feedback and take it.
Oh, sure. Thank you. Oh, sorry. I apologize. I can email them. I don't
go too far. Thank you. Thank you for being here, not here physically, but being at Houston Methodist and the Research Institute, and for many of the things that you're trying to improve in IRB, because I know our investigators, hassle with that and contracting on two arms. So to my understanding, therefore, there are 3 IRBs and there is an external IRB. Is that correct?
Well, we have many external IRBs.
Many external IRBs.
Yeah, so external IRBs are like our WCG, our ADBAR, Brainy. So those are our external IRBs.
And what goes to the external IRB versus the internal IRB?
Yeah, so I believe last January, Ed Jones made the directive that basically any phase 2, phase 3 type research can go to an external IRB right now. Any industry-sponsored studies that are multi-center can go to an external IRB right now. Any NIH-funded studies where you have a single IRB mandate, that can go to an external IRB as well. And then if you ever have any questions, you can always reach out to us as well, because there are always exceptions. And so we can make an exception to that rule if we need to. Those novel phase 1 single site studies, we try to keep those in-house.
Lovely. We may have time for a question if somebody...
And I'm sorry, and let me just add one other thing. So I was just on a webinar recently, and I don't know if any of you have heard, but FDA in the very near future, in the next couple of months, they're actually going to change their policy, and they're going to require a single IRB for any FDA regulated research. And so there will probably be more research going out to external IRBs than staying inside for our local.
Dr. Peden?
Great. That was a great presentation. Eric Feed with Vascular Surgery.
Thank you.
I guess a couple of questions. Has the use of external IRBs actually made the process more efficient and faster? And as you're restructuring and noticing these key indicators and such, what's the target for if I get a new trial and I want to get that going with industry sponsors that we're actually going to target to achieve?
Yeah, and so I think there are a couple of issues, right? So from an IRB perspective, is it quicker? So what my office is looking at are institutional requirements. We could probably do that review within 5 days and get you a letter and say, yes, you can go and you can start with your external IRB. Of course, you still have to meet contract requirements. You still have to meet, if it's a clinical trial, your coverage determination requirements. And so there's still institutional requirements and checks that are in place. And so I think we still have improvement to do there. I think my target would be, I've always told my staff, I think the benchmark for that is 5 days. And so if we receive a request for an external IRB, I want that approval going back out to the investigator and to the other IRB within 5 days. Because again, all I'm looking at is the informed consent document to make sure you have our boilerplate, which is HIPAA, privacy issues, and any injury language. That's all my office is looking for. And then I'm alerting contracts, I'm alerting IT if there are IT type issues so that they can do their piece. What I'm finding though is that forwarding it to other office is causing some delays. And so that's where I think we have to do a better job. Because it's taking too long across the spectrum. And there are offices that can get it done really quickly, but it does you no good because you still can't start the study.
So is there a target for when we get information about trial, submit the information, and then actually be able to start enrolling in the trial? Because currently it feels like it's your baby, right? Like you can see even actually deliver a child before you're ready to start try it.
Yes.
Meaning it's 9 months plus, right?
Right.
Sometimes for us in the competitive research environment, we're not able to even participate in some trials because of the rapid rollout to other centers.
Yeah.
She mentioned to you that there are...
Or is that too vague or too specific?
Yeah, now I know, and I wish Ed was here to answer that question, because that's probably more of an Ed question, because he has the oversight of, of everything, and I'm kind of like over my office. I know, I want to say currently, I think he's saying it's taking like 167 days to start a study. And I know he wants to get that down to 60 days at least, from start to finish. But I don't know for the external. I don't know if he said that's specific for external or for local IRB.
I mean, I've seen some of his I've seen some of his presentations, and what you see now will be improved. The performance indicators from an IRB, from contracting and everything else. Hopefully, we could do parallel processing. So, I think we're focused, all of us, to try to improve this better. With our efforts. Thank you.
Thank you. That was a great question.
Yeah, well, no, thank you for presenting it. And you presented a lot of things I didn't know. And I'm pretty clued into the stuff that's going on. So if I don't know about it, the chances of people sitting in this audience is impossible. And so what's the structure? Let's say you got somebody here who wants an investigator-sponsored program. How do they go through that? And it seems like you offered an upfront interview. Almost seems like that should be mandatory. Somebody comes, sits down with you, you know where all these resources are, this is how we can help you. And it needs to be a much more structured process, basically, moving it through. Because, you've heard from Eric about frustration. We have to be better than the other organizations. We're not Baylor, we're not Stanford in terms of the magnitude of this. Our opportunity is to be better and faster at moving this stuff through. And so, can tell us what the process is from concept to contacting your office, or what the recommendations are in terms of how we could help you help us?
Yeah, no, that's a great question. And I can tell you, being new to Methodist as well, I'm still learning a lot of those, and trying to answer a lot of those questions too. And I think that's the biggest frustration for me and my team. I'm new, my managers are new, which is why that SharePoint site that I talked to you about, I met with Ed about 3 weeks ago, I guess, and I kind of shared this vision with him. I gave him a roadmap, and I said, can we create something like this? Because I don't think anyone in the institution knows where to start, where to finish, where to go to for what. I wish I could share that SharePoint site with you, because it would be wonderful. I think just having that visual diagram, something that you could click on and say, if I want to start a protocol, these are all of the offices that you have to work with step by step.
In fact, we need one person, look to each.
Like a navigator.
And as on your site, we need somebody who the investigator could reach, you help manage.
Absolutely. And we've talked about with Ed as well, we've talked about having we call them protocol navigators that would live not in my office necessarily, because I only have one piece of it, but in a Raquel Bunge's office, because Raquel is in a unique position that she does know that entire spectrum. And so we have talked about protocol navigators, and I can definitely bring this up to Ed again when I have my one-on-one with him, because I think it's important, and I do think it's something that's needed at the institution. So those have been my observations since I arrived as well.
So when you and Ed are ready, to share that, the roadmap, I think, please send it to us so we can send it to all the researchers.
Yeah, we want
probably it's institute-wide.
Yeah, we would want to make sure that we account for all of the department's needs as well. So we definitely don't want to create this roadmap and then we miss a critical piece that you need.
Yeah, let me point out a comment. I know this drive that Craig was going to say. The clinicians here, we have targets, okay? We're not allowed to be equal to the other organizations. These guys need to be, our targets, for example, mortality, maybe 0.3% of what? One is equal. We need to approach the research operation with the same mentality. We can't be equal. We gotta be better in terms of the speed at which we execute on that. I think this is the equivalent of our length of stay. The length of stay is yours. We give you this, and it dwells in the administrative infrastructure for who knows how long. We are supposed to bring patients in and out faster than the rest of the day. And I think we need to take that same clinical mentality and bring it over into the research operation and say, here's your targets, you hit them, or you get a little red dot goes up against you, and then we work to see why we make those green.
Agree. We all have to be aligned. We have to know what your targets are in order to make sure that my KPIs and where I am aligns with that. So I completely agree. I did want to say as well, I think what's going to help move from a regulatory perspective us into the future is that our new IRB manager, her last position was actually as executive director of an independent IRB, so like an Advara, WCG type IRB. And so when she's looking at targets and she's saying, Wanda, we have to improve on our turnaround times, she's not really looking at academia. She's actually kind of benchmarking us right now against what is WCG doing? And if they can do it in 5 days, why can't we do it in 5 days? And how do we get there? So I think that's going to be very beneficial as well. So
Last question, Dr. Roy.
Hi. Treasurer Roy from Vascular. I just wanted to ask at this venue specifically, you had mentioned about AHA and NIH requiring data sharing and in approved databases. These are very expensive, and we shouldn't have to, reinvent the wheel each time. We're sharing very similar types of data, a lot of imaging data. How are we analyzing it? Which are we going to use? Bigshare? Are we going to use what? This mandate had come out in January 2023, and I still don't have any clear direction about where we're heading in terms of what we're agreeing upon as an institution to use for our data reporting. Is there any update on that?
yeah, I know the initiative for that doesn't live in my office. And so I believe that's probably Steve Jones. So probably be a great
He'll be here.
I know he'll be later. So I think it's Dr. Steve Jones and Dorothy. I can't think of Dorothy's last name right now, but I think they're the ones that are leading that initiative and making sure that we have appropriate databases that you can use to meet the NIH requirements right now. And from the image perspective, Ed is working with Dr. Diego Martin as well, just to identify how do we share images, how do we improve that process, and do we have some standardized databases to make it easier for you guys when you're collaborating on the outside?